Welcome to the CJD Foundation Virtual Conference and today's session, the 2022 Centers for Disease Control and Prevention Report on Prion Disease Surveillance. We thank our partners, the Centers for Disease Control and Prevention and the National Prion Disease Pathology Surveillance Center, for helping make the CJD Foundation Virtual Conference possible. We also thank all who have donated to the CJD Foundation or through Strides for CJD. Your gifts help support all the Foundation's programs: medical education, family support, research grants, and conference presentations like the one you'll see today. We're pleased to welcome Ryan Maddox, Epidemiologist at the CDC. Please enter your questions as they occur to you during the presentation. At the conclusion of the session, we'll address as many questions as time permits, focusing on tonight's topics.
Good evening. It's my pleasure to introduce Dr. Ryan Maddox tonight. He is an epidemiologist for Centers for Disease Control and Prevention in the Office for Prion Disease and Highly Infectious Zoonotic Diseases. And he's going to be presenting today on prion disease in the United States. Dr. Maddox and CDC has been a very big partner, both to the National Prion Disease Pathology Surveillance Center, as well as the CJD Foundation. He presents annually, and we're very excited to hear what he has to say today.
Thank you very much to the organizers for giving me the opportunity to once again speak to you about what we're doing at CDC with regards to prion diseases. Maybe next year, fingers crossed, we'll be able to do this in person, but for now, this is the next best thing. So thanks again. It's always a great honor to be able to speak to you about what we do. In case somehow you've missed it in the last 2 years or so, I can briefly tell you what CDC is. We are the nation's leading public health agency. We're tasked with controlling disease outbreaks, making sure the food and water are safe, helping people avoid leading causes of death, and reducing threats to the nation's health by global operations. So we are all over the place in 50 different countries, all over the United States. Our headquarters are in Atlanta, where I'm based, but there's more than 14,000 employees doing a lot of different jobs. Within CDC, we are housed within the National Center for Emerging and Zoonotic Infectious Diseases. And inside that, we're in the Division of High Consequence Pathogens and Pathology. And inside that division, we are in a small office called the Prion and Public Health Office. And our main job is surveillance for human prion diseases. And that includes things such as monitoring of the disease in the population, trying to see if there's occurrence of new prion diseases, and just in general gaining more knowledge about these diseases. So how do we accomplish our surveillance goals? Well, we start with death certificate data. As you're all unfortunately very much aware, these diseases are always fatal. So death certificate data is a great place to start if we want to get a good picture of how many cases of prion disease occur in any given year. However, death certificate data is not perfect. So we also use specimen testing data from the National Prion Disease Pathology Surveillance Center. And we use that data in conjunction with the death certificate data to come up with the most accurate surveillance numbers we can. And when we look at the death certificates, it's not just CJD. We look at different spellings of the word or misspellings of the word in things like GSS and FFI, prion disease, so we can come up with as many cases as possible using that source of data. So 2020 is our most recent year of data. And so looking at the period 2003 to 2020, there were 7,921 people that we identified as having prion disease. That comes out to an average age-adjusted incidence of 1.2 cases per million population. It was a little bit higher among males, that was 1.3 per million, and a little lower among females, 1.1 per million. And when we look at the older population where this disease is more common, that number goes up to 6.1 cases per million per year. Now, another way to look at this, though, is the number of deaths overall in any given year and how many of those would be expected to be prion disease. And looking at 2020, we came out with about one prion death for every 6,000 deaths overall for that year. So again, looking at the most recent year of data, 2020, we identified 568 cases of prion disease, and that's very close to what we saw in 2019, where we saw 571. And that comes out to an average age-adjusted incidence of 1.3 per million. Now, the one thing I wanted to share with regards to this is that when we started with the death certificate data and tried to find matches with the Prion Center data, we found matches for 87% of the cases in that death certificate data. And so that tells me that the Prion Center is doing an outstanding job in terms of their expertise and the awareness out there of the services that the center provides. Because 87% of these cases had some sort of specimen evaluated at the Prion Center. 10 of those cases were actually found to be negative through Prion Center autopsy, and so we removed those cases. At the same time, we added 40 cases that were autopsy confirmed that did not have a match in the death certificate data. The main thing I wanted to show here is just the trend from 2003 to 2020. And it's not as alarming as it might look, because even though you see those blue bars getting higher and higher, this is also over a period where the US population has been increasing. Not only that, the population has been aging. So you have more Americans, you have older Americans, and those people are going to be more susceptible to prion disease. Also, in recent years, we have had improvements in diagnostic testing, in surveillance. So this increase in cases is not unexpected. And if you look at the incidence alone over that period, it's much more stable. Again, 1.2, 1.3 per million over that time period. But wait, there's more. So there's something else we can look at, though. And I know you've probably heard about the RT-QuIC test. And this test is great, especially when it's positive. It strongly indicates prion disease. So the Prion Center is the chief tester of RT-QuIC. And when a case doesn't go to autopsy, they don't always have the date of death for patients for whom the RT-QuIC is positive. And so we identified a number of such cases in the Prion Center database without a date of death, and we don't know, did they die in 2020, 2019? But our estimate is that as many as 20% of cases in 2020 could be added on based on that RT-QuIC if we decide to include these highly probable cases. So the next step here would be to use the National Death Index to identify the dates of death for these RT-QuIC positive cases in the Prion Center data and add them to the appropriate years to obtain an even more accurate estimate of national prion disease incidence. And this isn't going to shoot the incidence up to 8 per million or 20 per million. It may mean 1.5, 1.6 per million. But looking at the National Death Index, trying to assign some dates of death to these cases, I think will be yet another step towards getting the most accurate data possible. One other group I'd like to focus on with our surveillance are the young cases, and we define those as cases less than 30 years of age. Most of these cases have a genetic mutation or other risk factor, for example, human growth hormone, or they might have variant CJD. Only 18 of these cases were identified from 2003 to 2020, and that comes out to 8 cases per billion per year. So very, very rare. Only 6 of those cases were sporadic. The rest were mostly familial, with 2 variant cases and 1 iatrogenic case that was linked to dura mater. Usually we only see 1 at most of these cases each year. 2019 was a little unusual in that we saw 3, but that's the way it works sometimes. You get your blips and then you go back down. So very unusual, but again, most of these cases are not sporadic. These diseases are still confirmed only by neuropathology. As great as the RT-QuIC test is, neuropathology still has a vital role. It can be a sentinel for unique and possibly emerging prion disease cases. The RT-QuIC is compared to that gold standard when we assess how good of a test it is. But as I mentioned earlier, the positive RT-QuIC in the context of a neuropsychiatric illness is strongly indicative of prion disease, and that's why we may try to include those cases in our incidence estimates. We find out about cases through a variety of mechanisms. Of course, the death certificate data I mentioned, as well as the Prion Center's specimen result data. We also hear about cases through public health departments, medical personnel, family members, the public, and the media. We often get the question, can a death certificate be amended? Because unfortunately, there are some death certificates that did not say CJD or prion disease on them. There is a way to do it. The process varies from state to state. So you would have to check with your state health department to find out what's appropriate for your situation if you wish to pursue that. But do know that if they had a specimen tested at the Prion Center, we would be aware of that case. So it wouldn't be lost to our surveillance simply because the death certificate lacked that diagnosis. Our surveillance, however, does not capture every single case. And so that's something we'd just like to put out there as well. The disease is reportable to some degree in almost all the states. However, a misdiagnosed case will still be a misdiagnosed case. So if you are in a state where it's reportable, but it's not identified as being CJD, it doesn't make much difference. But we do think that if it's reportable in a state, that could help facilitate some of the surveillance goals that we hope to accomplish. And we do provide funding to strategic states for enhanced surveillance activities that may be based on the presence of chronic wasting disease, which I'll talk about a little bit later, a high population, things like that may be a reason for enhanced surveillance. I've taken this slide out the last couple of years. I put it back in this year because we had a similar situation actually happen a few months ago, and that is clusters or reported clusters of prion disease. And the bottom line with these clusters is that fortunately, they inevitably dissolve when we take a closer look in collaboration with state and local health departments. The situation that I'm referring to, it was initially reported as 3 cases. They knew each other. They all had CJD at the same time. They were all hunters. So it initially appeared very concerning. When we took a closer look, however, one of those cases did not actually have prion disease. It was misreported as prion disease. Actually lived in an entirely different state in a different area as well. And the 2 remaining cases had very classic forms of CJD. The initially reported connection between the 2 was not actually there. And so, when we take a closer look at these clusters, this is what fortunately happens where the concern seems to go away somewhat when you put a magnifying glass on them. Variant CJD, fortunately, is not as big of a deal nowadays. I highlighted in red what I think is maybe the most important update, and that is 3 of the 4 cases reported since 2016 have actually been attributed to occupational exposure rather than consumption of contaminated beef. In other words, these were blamed on laboratory accidents where someone was working with a sample and had a situation with a needle stick or something and came down with variant CJD result of that, and not through a contaminated hamburger, for example. So that seems to be the way this disease is headed now. I'll briefly mention that 4 cases have been identified in this country total, and none of those were believed to be exposed to the infectious agent in North America. And to date, 233 cases worldwide since the disease was first identified in the mid-90s. Talk about tissue donation each year because there is some interest in that. The guidance, as far as I know, remains that people are ineligible if they've been diagnosed with any kind of prion disease, if they have a history in a blood relative. There's a geographic exclusion if there was time in the UK or Europe. Organ donation, there are no absolute exclusions. The FDA does not regulate organ donation, but organs may or may not be used depending on the outcome of a risk-benefit assessment by medical staff. So it really comes down to how much they need the organ in terms of whether they choose to use it or not. The image there is just an example of the considerations. The United States have begun organ transplants from living donors who have HIV. Years ago, that was even exclusion, but they find ways to potentially use them. But again, that's pending the outcome of that analysis. So right into the pandemic, about a month later or so, in April of 2020, the blood donation guidance was eased somewhat. And just now, 2 years later, they have been eased further. So now the new update as of May is that the donor deferral for geographic risk of BSE exposure has been removed. What does that mean? That means that the donors that were previously deferred for time spent in England, France, and Ireland, or for receipt of a blood transfusion in those areas may now be eligible if they meet all other eligibility requirements. So I know that's important to a lot of people that have wanted to donate in the past and have not been able to because of time spent in those places. But the FDA has now updated the guidance to allow donation. People that have been diagnosed with prion disease are still ineligible, or if they've received cadaveric pituitary human growth hormone treatment or a dura mater transplant, they would not be allowed to donate as well. But this will open up a lot of doors for people that have wanted to donate in the past and have been deferred. Final notes on blood donation. As far as we know, CJD is not transmissible through blood. That's the good news. Studies have shown that there has not been prion disease among people that have received blood from donors that have later been diagnosed with the disease. However, variant CJD has been transmitted through blood in a few cases. Funeral homes, embalming patients that have been autopsied can be safely performed. We can't force funeral homes to do this, though. And so one of the big tasks is to educate funeral directors about what we believe to be safe and what we believe to be unsafe. But some are going to be more open to this guidance than others. And from our website, the main quote that I like to reflect is, "There are no special interment, entombment, inurement, or cremation requirements for patients with CJD. Interment of bodies in closed caskets does not present a significant risk of environmental contamination, and cremated remains can be considered sterile as the infectious agent does not survive incineration range temperatures." I'll talk a little bit about chronic wasting disease. Of course, this is a prion disease of cervids, which would include deer, elk, moose, and reindeer. Highly transmissible within cervid populations. And I've highlighted in red the major update for now, which we are now over half the states in this country with identified CWD. And most recently this year, we've added Alabama, Louisiana, and North Carolina. So just 3 states already added this year, 29 states total, 2 Canadian provinces identified in Europe, in Norway, Finland, and Sweden as well. And you can see on this map that there's a lot of red. My crystal ball says in some of these places, for example, in North Carolina, with the one red county where it was just identified, next year you'll see more red there. This disease spreads easily, and when you start looking for it more, you inevitably find more cases. So should we be concerned about this, though? And the good news is that there's no strong epidemiologic evidence for the occurrence of CWD in people. However, we need to keep 3 things in mind. 1, looking at that map, you can see that CWD is being found in more areas, which of course means increased opportunities for humans to be exposed. We also talked about BSE and variant CJD earlier. There is a history of animal prion diseases causing diseases in humans. And finally, there are some animal studies that suggest the potential for CWD transmission to humans. So this isn't something we can take lightly. The CDC recommendations are, if you are hunting in an area where CWD has been identified, we would ask that you strongly consider testing your animal for the disease, because you cannot tell if the animal has CWD necessarily just by looking at it. And we also recommend that you do not eat a deer that has tested positive. The other ways that we look for whether this disease may cause trouble for the human population is we look at places where it's been found and conduct various studies to assess the situation. For example, CWD has been found in Wyoming and Colorado for decades. So we are looking at people who hunt in those states and identify those who die of prion disease to see if that rate is higher than we'd expect in the general population. We have a special study with our collaborators in Wisconsin, where we look at hunters that have actually admitted to eating deer that tested positive for the disease and following up those people over time and seeing if they have in fact died of prion disease. And the positive result of that study so far is that we have not found any prion disease in that special group. We even did a match just in the last couple of weeks with the most recent hunter data they submitted to us. However, these diseases have very long incubation periods, and so this is something that's going to have to go on for a long time to really get a better feeling about whether there can be transmission or not. And finally, we look at states where there's a lot of CWD versus states where it has not been found to assess any differences in the rate of human prion disease mortality. So one last thing I want to discuss in today's presentation is COVID-19 and how it does or does not relate to prion disease. I know a few people have had concerns about whether their loved one's diagnosis of prion disease is in some way related to COVID-19 or a vaccine they may have just received. In fact, there have been some reports out there that a connection may exist, and we do not believe that to be the case for several reasons. And so the considerations that I ask people to think about are, one, 89% of US adults have now received at least one vaccine shot, and that percentage is even higher among older adults, the population most likely to be diagnosed with prion disease. So given this high percentage, CJD will be diagnosed among vaccine recipients, sometimes in close proximity to when the shot was given, simply through chance alone. Prion diseases are characterized by long incubation periods, typically measured in years, not days, weeks, or months. So when someone gets a vaccine shot and a week later says, I just had onset with prion disease, there must be a connection, that's not what we know about the way these diseases work. Looking at 2020, our most recent year of data, the number that I showed earlier, very similar to what the number was in 2019. So there didn't seem to be an uptick based on the COVID-19 pandemic causing increased prion disease. And finally, there have been cases reported to the Prion Center where there was a presumed connection to the COVID vaccine, and they have not identified any unusual neuropathological features in these patients. So there's a lot of reasons why we would not think that there'd be a relationship either between COVID-19 itself or any of the vaccines and prion disease. Final thoughts, these diseases are unique and cause challenges, when we look at them for a variety of reasons. And we have various activities to look at them. We conduct surveillance through various methods. We investigate cases of interest in collaboration with affected states, and we try to provide the best advice we can on prion disease related issues. We collaborate with our valuable partners, the CJD Foundation, the National Prion Disease Pathology Surveillance Center, and medical and public health personnel. And finally, improvements in pre-mortem diagnostic testing, notably the RT-QuIC test, should benefit these surveillance efforts. But we need to get more information on those cases, like the date of death, as I mentioned, and autopsy remains so important because of the special additional information that provides. These are resources that I'm sure you're very familiar with, the Foundation, the CDC, and the NPD PSC. And of course, I'd like to thank my colleagues and all the wonderful people at the Foundation, at the Prion Center, and state and local public health departments that assist us with our surveillance efforts. Thank you.
Thank you very much, Ryan. That was a great talk. You covered many things, and answered a lot of questions that I know a lot of our families have been asking us. Just a reminder for those who are watching live, you can ask questions by typing it in the question box and we will try to get to them. So we do have some questions already. One question we have is regarding whether or not reporting for CJD or suspected CJD is mandatory.
Okay, well, thank you for that question. As far as reporting to the CDC, it's not mandatory. Different states have different rules as far as reporting goes. And I mentioned in one of my slides that most states do have it reportable in some way. And what I mean by that is they may have restrictions. For example, it's reportable to the state health department if the patient is less than 55 years of age. But again, most states do have some requirements for it to be reported. If they don't have it specifically listed as a reportable disease in their state, they may have some stipulation that any disease that's very unusual should be reported, and that could potentially include an unusual presenting prion disease case as well.
Thanks, Ryan. Just as a devil's advocate, when you're looking at overall frequency of prion disease over time, and you're trying to follow that as an epidemiologist, how important would reporting be for that? And if a case is not reported in the way that you just mentioned, would we worry about missing cases?
Right. Okay. So that's a good question. And when I showed that graph with the blue bars with the number increasing over time, there were improvements in surveillance over that time period. And so that can kind of be a reflection of how good surveillance is. And so one thing we've attempted to do over the years is make improvements in our surveillance. That's included things like utilizing the data from the National Prion Disease Pathology Surveillance Center in conjunction with the death certificate data. It's included things, as you're well aware of, Brian, of using those advancements in diagnostic testing like the RT-QuIC to get better diagnoses before the patient's death, so we can hopefully get more accurate diagnoses on the death certificates. So all these things can lead to improvements in our surveillance numbers, and we need to consider that when we look at the trend over time.
So two chronic wasting disease questions. One is, where in the US is chronic wasting disease found? And the second question is, it looks like we're following CWD and wild game consumption prospectively in some of the studies that you're talking about. Are there ways that we can examine that retrospectively in prion disease patients who may have consumed venison or wild game?
Okay, thank you. So I showed a map, and it was only briefly, but you may recall seeing a map of the United States in my presentation with a lot of red on it. And that was representing counties where the disease has been identified. So it's been found in 29 states now, mostly in the West, but also around the Wisconsin area. The Southeast has been largely spared, although North Carolina and Alabama are our two most recent states. So it is creeping into other states as well. And we always say that just because it hasn't been found in a state doesn't mean it's not there yet. There can be differences in how much testing is done and where the testing is performed that can influence findings, of course. As far as retrospectively looking at the disease, that's one of the strengths of the studies that we're performing in Wyoming and Colorado, where CWD has been around for decades, because we are looking at people that purchased hunting licenses maybe 20 years ago. And so we have that time built in where we compare those names to the National Death Index to see if those people have passed away, and if they have they died of prion disease? And we can compare those rates to what we'd expect in the general population. The Prion Center does attempt to collect hunting information on the specimens that they receive. And in addition, if we find out about a case that may have had an exposure, there is an attempt to gather additional samples for analysis as well. So there are definitely different mechanisms we can use to assess whether transmission may or may not occur.
Right. Thank you for that, Ryan. I think it's important, especially for people that may have not have heard you talk before. At the very beginning, you mentioned two numbers. One number was 1 in a million, and the other number was 1 in 6,000. Can you talk a little bit about what those two numbers are and what they mean?
Yes, because they sound a lot different, don't they? So the 1 in a million, and more accurately, 1.2, 1.3 per million, comes from looking at the cases that we have and in assessing the incidence calculations. The 1 per 6,000 is a different way of looking at it. So if we look at all the cases that died in the country, for example, in 2020, all the cases that died, and then we count the number of prion disease cases, which I believe I said was 568. So we divide those two numbers, and that comes out to about 1 prion disease case for every 6,000 deaths. And so it's kind of two different ways of looking at the occurrence of disease in the population.
So if one were going to look at lifetime risk, would that equate to either of those numbers, or would it be a different number?
Yeah, I mean, the lifetime risk is more similar to the second statistic. So, you know, this comes up a lot where we use the baseball stadium analogy. You know, if a bunch of people visited a baseball stadium at some point, you know, what are the odds that several of them might get prion disease? And it's actually not that uncommon, just given the numbers of people that could fill that stadium.
Right. So this is a little bit of a scientific question. So maybe a little bit of context would be helpful before you answered it. But one of our public health colleagues asked if you knew what genotype the Durham matter associated case was.
It's been a while. Rather than say the wrong thing, I'll just say I don't recall for sure. No. I could find out if they want to provide their information. I can certainly let them know.
For those that aren't familiar with genotype or why it even matters in specific cases, would you mind just giving a little discussion about what that means and why we care?
Yeah, I mean, in the general population, someone can be what we call MM, MV, or VV. Methionine, 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 valine, or valine, valine. And so there's nothing wrong with any of those, but typically methionine, methionine may be more susceptible to prion disease, especially with variant CJD, the form of prion disease linked to mad cow disease, where almost 100% of those cases were in fact methionine, methionine. So it's an interesting way of looking at people and seeing whether they may be more susceptible or less susceptible to certain exposures.
Another question was, to what degree do you think that CJD deaths are underreported?
Yeah, and that's a very interesting question and something we've pondered a lot, especially lately. You know, we feel like we have a pretty good grasp over what's going on in the country year to year. And during my presentation, I mentioned this new subset of cases, given the excellent RT-QuIC test, that are highly probable based on the positive test result. And we've not included them traditionally because they have not been confirmed. However, inclusion of those cases could account for about 20% more cases each year. And again, this is going to take closer investigation on our part to get a more firm grasp on what the exact numbers are going to be. But those represent a group, for example, that have not been included necessarily in the numbers that we've shared. Are there more cases out there that have not been reported? Of course, not everyone may have a CSF sample sent to the Prion Center for that RT-QuIC analysis. There's going to be a group of cases that are misdiagnosed as Alzheimer's disease or any other number of neurodegenerative diseases. We're going to have those cases that are unusual, that test RT-QuIC negative and don't go to autopsy, but were in fact prion disease cases, and those do happen. So we certainly make the claim that we are not going to pick up 100% of cases. Putting an estimate on how many cases we're missing, I'm not able to do, but I can say that I feel like we get the vast majority of cases in our surveillance. And that's why in my presentation, I mentioned that, we may see a bump to 1.5, 1.6 per million. In fact, on our website, we say we could expect anything in the range of 1 to 2 per million. But I don't see this jumping up one day like, oh, you know what? We took a closer look and it's 20 per million. I don't think we're that far off.
And I suppose reporting is a bit in the eye of the beholder. If you look at it from the prion surveillance standpoint, neuropathologically, 30% of the cases that are referred to us for autopsy wind up not being prion disease. So one could argue that there's perhaps underreporting, but perhaps overreporting as well.
Exactly. And there may be a certain balance there. The death certificate data I mentioned, the only cases we remove are those that match with the prion center data and have that negative autopsy. But you have 13% of cases in that death certificate data. And again, that's based on the 87% that we matched. There's 13% remaining that did not match. We have no way of confirming whether those are true cases or not. The assumption would be most of the time the neurologist or whoever it was got it right. But certainly that's not going to be a 100% situation.
I guess a very similar and related question is, how does the incidence of CJD in the US compared to the rest of the world?
Right, and that's a very interesting comparison because not every country has the same capacity for surveillance that we're lucky to have here. So just because a country might say we only have, 0.25 cases per million, that doesn't necessarily mean that's the true surveillance situation in that country. So we have to consider that when we make these comparisons. If you look at maybe similar countries with similar capacity, they all typically fall within the same range of 1 to 2.5. They're kind of in that same ballpark. I don't know of any out there that are reporting, 4 or 5 per million or anything like that. There is kind of a consensus among similar countries as far as the numbers they're seeing. Something I should mention is that we have found racial differences when we've looked at this, and other groups have as well, where African Americans, for example, seem to have a lower risk of prion disease compared to whites. And so if a country has a higher Black population, for example, that could influence their prion disease numbers.
That's an interesting point, Ryan. What do you make of that? Could it be that there's some type of genetic modifier? Could it be things like diagnosis and access to care? Any guess on why that's the case?
Yeah, and I think it could be both those things. My assumption is that it's more in terms of genetics. We also see differences with other racial groups as well. And access to care could play into it somewhat. At the same time, we've seen that same difference over quite a long period of time, where presumably some of access to care may have been improved. It's been, consistently reported that those differences are there. And so I think there is a strong genetic component.
One person had a question regarding whether or not CJD could be transmitted through a kidney transplant. So now might also be a good time to talk about what types of medical procedures might be a risk factor.
Yeah, that's an excellent question. And we don't know. I mean, I can tell you that I'm not aware of any cases in the literature where it has been transmitted through a kidney transplant. Really, the main transplant-related transmission event has been through corneal transplants. There's been one definite case of that happening. And I say definite because the donor and the recipient were both autopsy confirmed with prion disease. So there's a very strong link between the donor of the cornea and the recipient. There's been one probable case where they both were diagnosed with CJD, but only one was autopsy confirmed. There have been cases many decades ago, actually, of neurosurgical instruments and EEG electrodes transmitting the disease. We are not aware of any recent cases being transmitted through neurosurgical instruments. The tricky thing there is the incubation period. So if you are diagnosed with prion disease and you had a brain surgery 20 years ago, it's hard to link your current illness to something that happened that far back. The hospital may not even exist anymore. The medical records certainly may be difficult to get your hands on to see if, for example, someone else was treated the same day for prion disease and the same instruments were used. So it's difficult to make that connection, but we haven't really been aware of too many reports. There have been a few things we've looked in over the years where we feel like maybe there could be a connection between a neurosurgical procedure. So certainly we don't take that risk lightly. In fact, we have recommendations on our website for hospitals to consider if they are going to be conducting surgeries on a suspected prion disease case in terms of what to do with those instruments, because certainly there is a risk there that we believe exists. Getting back to the kidney, our main concern are surgeries that involve the brain or spinal cord. But if I were giving advice to a doctor who is about to perform a kidney surgery, I would advise them to consider the possibility anyway that transmission could be an issue. However, again, I'm not aware of any cases where that's actually occurred.
And Ryan, you had a very nice study that you did several years ago looking specifically at corneal transplants, which are actually surprisingly common, and the likelihood that people that get a known procedure that could transmit prion disease may actually not have an acquired prion disease, but a sporadic prion disease. Can you talk a little bit about that?
Yeah, that's right, Brian. So the people that are most likely to get a cornea are, in fact, the older population. And that's also the population most likely to, unfortunately, get prion disease. So in that group of the older population with prion disease, it's not surprising to find out that some of them have, in fact, received a cornea. And we find out about these cases from time to time. Brian may let us know, or we may find out from a health department or from the patient's family even, saying, okay, my loved one has CJD. You should know that they had a corneal transplant in 2015. Is there a connection? So when we find out about these cases, we try to work with the state and local health departments to get information on the donors of those corneas. And what we have found through all these investigations is that, fortunately, connections have been very unlikely. And I say that because the donor might have been, for example, 20 years old. And that would, of course, be a very unlikely age to have prion disease. They may have died in a motorcycle accident. They may have had no symptoms at the time of their death that indicated any kind of undiagnosed prion disease. And the reason I say undiagnosed is because if it was diagnosed prion disease in the donor, they would have been excluded right away from even donating as far as the cornea goes. So fortunately, when we've done these investigations with our state and local partners, working with the eye banks, we've been able to find out that the donors were not considered high risk for undiagnosed prion disease that could have transmitted to the recipient, and that these are actually coincidental cases of prion disease in those people with a history of the transplant.
So this next question I also wanted to ask you as well. On your slide regarding variant CJD, you mentioned that 3 out of the 4 cases reported since 2016 of variant CJD were occupational. Could you talk a little bit about what you mean by occupational in that setting? And I think most of us know about a case in France and Italy, but that third case, could you talk a little bit about as well?
Yes, and I can't say too much about it. I believe it's still under investigation, but my understanding of the situation is it's also a case in France where there was a person working in a laboratory setting with tissue that contained the infectious agent, and they had an unfortunate accident that years later led to their illness onset. So these aren't situations where someone pricked their finger and then a week later, started feeling sick. The one case that's most reported in the literature was the French case that Brian mentioned. I believe it goes back to 2010 or 2012, where the accident actually occurred. And she knew at the time that the accident had happened, and was very concerned over the following years that she might, in fact, come down with disease. And unfortunately, that's exactly what eventually happened. So these occupational exposures are among people working in a laboratory setting with tissues that would be considered, hazardous and just unfortunate that they've happened that way.
And I think, again, Ryan, we know the most about the one French case that you talked about, but I think it's very important to, state that this happened specifically in a prion laboratory, and a prion laboratory using animal prions in a very special experimental model that would have heightened the risk of infectivity. So
Yes.
It's not like this is, a medical assistant working in a laboratory in a hospital. This was a very specific circumstance.
Yes, thanks for pointing that out. These were people working specifically with that kind of thing and in a very specific setting. Yes.
Are you able to say if those other two cases follow suit with that?
It's my understanding that they were. In fact, I don't know much about the Italian case. It was mentioned just in the kind of final thoughts of one of the reports, like, oh, by the way, there was also an Italian case. And so they didn't get into details there, and I haven't been able to track down specifics on that particular situation.
Are there any identifiable risk factors that might increase the risk of CJD?
Just among the general population?
I think they're asking, because we talked about the medically induced ones, right? For what we consider sporadic CJD, are there any known environmental risk factors?
There don't seem to be for sporadic CJD. There are certainly known risk for exposure, such as, I briefly mentioned human growth hormone and duramatter. If you receive that, fortunately, that risk is very low now. We still see cases from time to time because of the extremely long incubation periods. Someone that may have received human growth hormone in the early 1970s could still come down with prion disease now if it was in fact contaminated. But as far as other risk factors, the biggest risk factor is age. The older population is more susceptible to prion disease. We don't see so many cases less than 55, and I mentioned less than 30. It's extremely rare.
Yeah, so apropos to that, there's one family member watching whose mother was elderly. He was diagnosed with having dementia, and the neurologist seeing her mother at the time was somewhat dismissive, saying that it was just dementia because of her age. So can you talk about what's being done to make doctors more aware that elderly patients could be at risk for this disease?
Yeah, I mean, that's very unfortunate. And what I tell people, and this group especially, is that situations like this can be educational experiences. Neurologists, they don't see prion disease necessarily on a daily basis or a yearly basis. It's not the most common diagnosis they're going to be giving out, and not something they necessarily study extensively in school. And so anytime that there's a situation where they're not considering prion disease as an opportunity to teach them about prion disease. And so this goes for infection control as well. Hospitals unfortunately don't always know to use more stringent sterilization with the instruments if prion disease is suspected. And they can sometimes get into a lot of trouble if they use those instruments on other patients afterwards, because they may have to notify those patients. There may be legal considerations and they find out the hard way. And so when these situations happen, sometimes they're near misses where it turns out to not be prion disease. We still say, well, look, now you've learned your lesson. You need to think about prion disease whenever you're looking at a patient where you don't know the diagnosis and they have the following symptoms. If there's a dementia of unknown cause that's rapidly progressive, you need to consider prion disease as a possibility. And that's one of the great things about the Prion Center. They can submit the CSF and get a very good idea of a diagnosis now, from the center performing those analyses.
So if someone is caring for someone with CJD, what precautions would you recommend that they take?
One of the good things, if I could even use that phrase regarding prion disease, is it's not easily transmitted in the traditional sense. If someone sneezes on you, for example, if you touch them, you're not going to come down with the disease based on our knowledge of what's going on. The real dangers of exposure are, like I mentioned, with an instrument touching the brain of someone with the disease and then touching your brain. So for someone taking care of someone in their home, we don't expect it to be transmitted through the bed sheets or anything like that. If there is a situation, more like in a hospital setting where there's cerebrospinal fluid leaks or something like that, then certainly certain precautions would need to be taken. But we don't really see that in a more casual setting. And I mentioned earlier that we have not even found a case that we know of where the disease has been transmitted through blood, at least with classic CJD. So we don't, tell people that they need to take, really special precautions when they're caring for their loved ones in the home setting.
So many of these family members, unfortunately, when their loved ones progress in the disease, get a lot of urinary and bowel incontinence. Is that anything they need to be concerned about when they do their caregiving tasks with those patients?
Not that I'm aware of, no.
This is an interesting question. I'll be interested to see how you answer it. What do you think the incubation time for sporadic CJD may be?
Yeah, that is a tough one, and it's an important one, especially with a lot of the talk now about potential treatments. And you really have to catch it early for some of these treatments to be effective. So how far back can you go? When is this really going to show up? And so one of the small things that my understanding of going on now is, a group of people with a mutation that might have familial CJD or a genetic form of prion disease, and regularly testing their CSF, their cerebrospinal fluid, or their blood, and seeing if there are changes while they're feeling healthy, and seeing when they might be able to detect a positive RT-QuIC, for example, prior to illness onset. So that will help a little bit in terms of seeing how far back this goes. There are, a lot of considerations that have to be considered. You have to look at, is there a kind of a threshold number of abnormal prions before illness onset really occurs? How far back can you go? I don't think it's something that happens quickly, but I certainly can't assign a value to how far back it goes.
So somewhat similar, in your talk about RT-QuIC is, what is the disagreement that we see between RT-QuIC and neuropathology at autopsy? And what is the diagnostic accuracy for RT-QuIC to capture all forms of prion disease?
Yeah, so RT-QuIC does have some limitations. As great of a test as it is, and like I said, when it's positive, you can almost be sure it's positive if it's in the right context. But there are certain groups where it's not as good. And Brian's group did some work on this, looking at cases that they'd evaluated and certain subtypes. We talked earlier about valine. Valine people might be less likely to have a positive RT-QuIC. Different genetic forms may be less likely. So and you know, one of the major ones as well, a variant CJD, we would not expect a positive RT-QuIC for. So there are groups that are less likely to have the positive RT-QuIC. And again, that's one reason why we say try to get the autopsy if you can, to get that full picture, because looking at the brain is really what's going to give you that final word in terms of the diagnosis. You know, as good as the RT-QuIC test is, you can't get the full answer necessarily.
Should surgeons who have treated a patient prior to having prion disease be informed after that patient passes? So I guess we could include all types of surgeons, but also healthcare providers in general, I guess.
And let me just understand, I make sure I understand the question. So you're saying before illness onset, they were treated, then they had illness onset, and whether to go back and let them know?
Yep, correct.
Right. So it's a tricky question, and I'll put it in the context of infection control. If we found out, for example, that someone had a knee surgery in 2018 and in 2020 they had illness onset, we would not feel an obligation to go back to the 2018 provider and tell them of this diagnosis. Given the fact that the patient was asymptomatic and the nature of the surgery, we would not feel like that would be necessary. So we do need to consider the time period that we're talking about and the nature of the procedure as well when we're making those considerations.
So we're winding down, and I hate to do this to you, but you know, we've been getting this question a lot at the center, and the foundation has as well, about the COVID vaccine and association with CJD. And I thought you did an excellent job describing, you know, the very real possibility of coincidence. I was thinking about this on the way home tonight. If the vast majority of older adults in the US have been vaccinated, fully vaccinated, they would have had 3 or 4 vaccines doses, right? And, you know, if we expect about 500 cases of CJD a year, we're talking about possible coincidental cases in potentially hundreds of patients. Is that accurate?
Yeah, I mean, that's exactly right.
So I think, you know, this brings up an important point, because you know, this is a rare disease, and I just pointed out that you could potentially have coincidence in maybe hundreds of patients. That's why surveillance is so important, especially with rare diseases, because even 1 case or 2 cases could seem significant. But again, you really have to analyze that in the broader context of statistics and likelihood and what else is going on.
Yes.
Anything else you wanted to add to that?
No, I think you put it very well. You know, when you're dealing with a group that, you know, has largely been exposed, and in this case, exposed means vaccinated or had COVID, you are going to expect these cases. It would be more surprising if we did not see any prion disease cases in that group, based on the sheer volume of people that have had the disease or been vaccinated at this point.
Ryan, we really appreciate you taking the time tonight to answer these questions. On behalf of the families, thank you for all that you do for prion disease, and especially in the last 2 or 3 years with COVID, and now unfortunately monkeypox. We know you guys have been very busy, and we really appreciate the service that you do for us. So thank you.
Thank you, Brian. It was a pleasure to be here. Thank you.